I'm going to be talking about combination of immunotherapy and chemotherapy, and I'm going to be sort of using mobile phones as a kind of reference for this, and we'll come to why that might be relevant in a sec. So here's what I'm going to cover really briefly. So I'm going to be talking a bit about efficacy of these combinations in small cell lung cancer, adenocarcinoma and squamous carcinoma, and then just briefly talk a bit about toxicity of combinations and cost. I'm not going to rehash the whole toxicity thing because you guys will lose your minds. So let's talk about small cells. So small cell lung cancer, probably about 12% of lung cancer in Australia. And it's aggressive, generally treated with chemotherapy plus or minus radiation, and divided into limited and extensive stage. So extensive stage, traditionally we would say, has a survival of about 6 to 12 months. And now this is a paper, just in really small text, published in 1992, which for me doesn't feel like that long ago, but for young people feels like, ancient history. And to give you an idea, that's what a mobile phone looked like from 1992. And this is Jim Bishop and George Morstan, two of the really pivotal figures in the original VCCC. And Jim and George were actually the co-authors of this paper on the use of carboplatin-containing regimens, including carbotoposide, for small cell lung cancer. And I can tell you that there's been pretty minimal advances in the treatment of small cell lung cancer from a chemotherapy point of view, before Shankar just jumps up and down and starts screaming his head off. Yeah, sure, there's been radiation advances, but from a chemo point of view, that's still where we're at with carbotoposide. Until this year, so this is a study from the World Lung Cancer Conference, which I didn't go to, but that's cool because I get to go away later this week. But essentially this was comparing the standard backbone, George and Jim's backbone of carbotoposide with atezolizumab. Essentially you've got your standard chemo plus placebo compared to plus placebo, or the same thing with atezolizumab immunotherapy. And this is the overall survival curve from that study. And so there's a clear survival benefit from adding the immunotherapy. And it's no joke to say that this is the single biggest advance in systemic therapy terms since 1992. But really, if we think about how big an advance that is it really massive? Well, if we look at the progression-free survival numbers for this study, it's really not, because if you're at 12 months, in fact, you've only got 12% of patients who are free of progression versus 5%. So you're really only helping at 12 months a relatively small patient population. So you do get benefit, but it's not really long-lasting benefit in the majority of patients. So, what's the significance of this? Is this like moving from a 1992 Nokia to an incredibly expensive iPhone to this year? And it's really not. It's more like moving from a 1992 Nokia to a BlackBerry. So it's an advance, but it's not like the game changer that we're looking for. Those of you who had BlackBerries, 10 years ago probably thought it was that big of a game changer, but, everything looks different with hindsight. So the next group of patients I want to talk about is adenocarcinoma. So adenocarcinoma is obviously the most common type of lung cancer in Australia, and the survival of stage 4 patients is still really less than 12 months on average, though it's different if you've got targetable mutations or high PD-L1 expression. And a study in 2002 by Schiller looked at 4 different types of chemotherapy combinations. So these are doublet chemotherapies in first line. And the 2 things to note about this is you couldn't really pick between the 4 different regimens. And overall, the survival results were pretty grim. With that 12 months, maybe 35% of patients still alive. Now, Gavin made the point earlier, which I completely agree with. You can't compare between studies because the inclusion criteria of more recent studies have got more rigorous. So some of the survival benefit in more recent studies just means that you excluded a lot of patients who would have been included in studies in 2002. So we have to be careful about that. But even allowing for that, it looked pretty grim, even though the mobile phone at the time was pretty cool, this Samsung sort of 2002 phone. The survival results from the study were not so great. So this is the recent Keynote 189 study that's comparing chemotherapy. And I should say that since 2002, what has improved is there's been a few advances. So there's been angiogenesis and pemetrexed, as two examples, and maintenance pemetrexed chemotherapy. So the backbone of this for adenocarcinoma is one of the standards, which would be really platinum plus pemetrexed plus placebo, or the same combo with pembrolizumab, and they can continue with maintenance therapy, including a combo maintenance of pemetrexed. And importantly, in this study, the placebo arm could then switch over to pembrolizumab. And so despite that crossover, there's some really impressive overall survival results from this study, with an overall survival of nearly 70% at 12 months, and a very large difference between the arms in terms of a chemotherapy study. And the other thing that's interesting is if you look at the subgroups here, in fact, the patients with relatively low PD-L1 expression, which traditionally you would have thought wouldn't get that much benefit, still got benefit. So this, again, comes back to, is the chemo causing antigen release or doing something that's encouraging the benefit of the immunotherapy? So this is a similar study, but this time with a different immunotherapy drug, atezolizumab. And, I won't bore you with the details, but this has been mainly looked at in terms of progression-free survival. And again, we're seeing a progression-free survival benefit to adding the immunotherapy drug to the same backbone that was in the pembrolizumab study. So similar results for atezolizumab. The interim overall survival analysis is not, so these aren't the final data, and it wasn't quite statistically significant with a p-value of 0.8, but it's likely to become significant with further follow-up. There's a lot of censoring in this part of the curve, as you can see. So this is another study of atezolizumab, but different backbone, one of the standard American backbones, the other standard American backbone of carboplatin paclitaxel, and bevacizumab. So, Americans love their bevacizumab. And this is a 3-arm study, so you can get, some bevacizumab, or you can get the hamburger with the lot, essentially in the middle, or you can get some atezolizumab. And in terms of the overall survival, so this is just comparing arms B and C, which is the hamburger with the lot, or the bevacizumab and platinum. So this is the one where the immunotherapy is being added in. And again, we're seeing overall survival benefit from adding immunotherapy. And again, we're also seeing that regardless of PD-L1 expression, there does seem to be a benefit. So relatively consistent here. The other drug is nivolumab. There's a few others, but the other one I want to talk about is nivolumab. So this is sort of ice cream headache-inducing study, Checkmate 227, in terms of its study design. But the bit that I want to focus on is the bit of... So this is a group with patients with low PD-L1 expression, and the subgroup analysis that they've looked at is the 2 arms comparing chemotherapy and nivolumab plus chemotherapy. Though, as you can see, there's lots of other arms in the study, which I'm not going to go into. And again, what we're seeing is in this group with low PD-L1 expression, there's a progression-free survival benefit from adding nivolumab to chemotherapy. Right there with the big arrow. So where are we at? So it's a bit like choosing a smartphone in 2018, right? So you've got lots of choices. They all look pretty effective. It's actually hard to make a choice between them with the data we've got at the moment, and they're all hellishly expensive. Okay, so squamous carcinoma. Where are we at with squamous carcinoma? So it's more common than small cell, but less common than adeno, usually related to smoking, and stage 4 prognosis is generally worse than for adenocarcinoma. So this is the study of atezolizumab, IMPAL 131, atezo plus chemo. Or the other 2 arms, so there's 2 atezolizumab arms with different chemotherapies, paclitaxel or nab-paclitaxel, and the control arms with carboplatin and nab-paclitaxel. Again, the progression-free survival does look like there's a benefit, and it's highly statistically significant, but the overall survival lines actually look very unexciting, but keep in mind that this is not mature data, but really no significant difference between the arms at this stage, so that further information is awaited in the squamous group, basically. A couple of words about toxicity. So don't worry about the bit that they've circled here. This is the slide from AACR. I don't care about that. But what I do care about is this, which is the difference in grade 3 to 5 toxicity, keeping in mind that grade 3 means moderately severe toxicity, grade 5 means you're dead. And there's really pretty minimal difference between adverse events between the arms, which means that adding immunotherapy to chemotherapy in this study didn't really have much in the way of significant impact on toxicity. Now, is that consistent? It is. So in the IMPOWER 150 study, the study with, the bevacizumab plus atezo plus platinum, really interestingly, so they didn't draw any attention to this in the presentation at ASCO, but the arm that had the least toxicity, at least numerically, was the simplest arm, the atezo plus chemo arm. If you left out bev, you got less toxicity. So that'll be an interesting marketing approach for that when they get their mature results. Because, it looks possibly like bev's going to, add very little value. But we'll wait and see what happens. And this is the small cell study, and again, very little in the way of additional toxicity. So, again, pretty consistent message, not much additional toxicity. Finally, talking about cost. So, Pembro on a cost share program, so this is not the true cost of Pembro, this is like, MSD being really, really generous in terms of the international cost, is still about $6,000 every 3 weeks. All right, so that again, so this is, if you're going to buy the top of the line iPhone XS, you're going to be spending like 2-point-something K on it, and then probably the glass backing will make it slip out of your hand, and you'll drop it, and then be spending another 2.4 K the next day. So, I think you've got to really think about the value of the things that as a society, we're spending money on. And this is the impact of that in the US. So you would have seen there's a number of articles around this at the moment. There was one really recently, even after this one, saying something like 44-something% of US people with cancer exhaust all their financial assets by year 2 of their cancer treatment if they live that long. And this is so cost of cancer drugs, median household income versus cost of new cancer drugs in the US. So this is clear that this is unsustainable. I don't know what the answer to this is, but it's definitely not sustainable. So in conclusion, combination immunotherapy with chemo improves lung cancer survival in adenocarcinoma and small cell. We're really waiting for the final results in squamous carcinoma. It does appear to be effective in patients with low PD-L1 expression, with minimal traditional toxicity, but with high financial toxicity.